Please start, ma'am. We are live.
Yeah, hi. Good evening, all.
Namaskar and good evening, everyone. A very warm welcome on the webinar on innovation in cancer care 2026. With immense pleasure, I would like to invite Dr. Ravi Tippeswamy. He's consultant medical oncologist at CG Cancer Care Center, Bengaluru. He is also the convener of this webinar. Over to you, sir.
Yeah, good evening, all, and I thank all the distinguished speakers and dear colleagues for this meeting. And I thank Horizon also for helping us in conducting the meeting. So it's my pleasure to welcome you all for the today's webinar, Innovation in Cancer Care, where we will discuss the clinical reality and how we manage our day-to-day cases and how we can apply this knowledge as a practical advances in our day-to-day practice. So with this, I will hand over the session to the conference team and they will take over. Over to you, Pooja Madam.
Thank you, sir. For the first session, I would like to invite Dr. Sai Vivek V. He is consultant medical and hemato-oncologist in Apex Hospitals, Bengaluru. This session is sponsored by Glenmark. Over to you, sir.
Yeah, hi. Good evening. Thank you for this opportunity. Thank you, Ravi sir. And I'll just start sharing my screen. It's not letting me share. I think you could request multiple. Someone else is sharing, I think.
So now you can share.
Yeah, got it. Yeah, I hope my screen is visible and I'm clearly
Yes, sir.
audible.
Yes, sir. It is visible and you are.
Yeah. So good evening, everyone. So today, briefly, I'll be talking about the role of tislelizumab in the management of esophageal carcinoma. And as we all know, there are multiple agents of immunotherapy that we have available with us in the clinic for usage in different cancers. So it becomes the responsibility of the treating physician to choose what is most effective, both in terms of efficacy and logistics for the patient. So, with that being said, it is important for us to know which agent has the approval in which cancer and which can provide the maximum outcomes in terms of survival and progression-free survival. So this would be the brief scope of the presentation for today. We'll talk about the PD-1, PD-L1 inhibitor landscape. Then why is tislelizumab different? We'll spend a few minutes on that and then go straight to the clinical evidence in mainly esophageal squamous cell carcinomas, first line and second line, and gastric cancers. And we'll conclude with the information about adverse events. So from 2014, when nivolumab was first approved for melanoma, we have multiple PD-1 and PD-L1 inhibitors that we have available, and approval status has been given in many cancers. As we can see here in this busy slide, so different cancers, there are different agents which are available, and that actually makes us start to choose between each agent, and multiple choices for our patients are available, which is definitely a good thing. So how is tislelizumab different? It is an IgG4 monoclonal antibody against PD-1. Okay, so we start differentiating first whether it's a PD-1 inhibitor or a PD-L1 inhibitor. This is a PD-1 inhibitor which blocks the binding of PD-1 to PD-L1 and L2. So it is different from others because of the uniqueness in the binding. It binds to different epitopes on PD-1 compared to the other agents that we know of. The dosage that is recommended is 200 milligrams, and there are more than 20 potentially registration enabling clinical trials that are going on in around 35 countries, and over 13,000 patients have already received this drug. So the safety and the efficacy has already been proven beyond any doubt. So if you look at approvals, it's there in almost around 10 different cancer subsets. and universal approval or worldwide approval is there for quite a few, as we can see on the left-hand side, for lung, for esophageal squamous cell carcinomas, and even gastric cancers. It has been approved along with China, even in European Union and United States. So that actually increases our faith in the particular molecule when different countries have approved it for different indications. So 12 approved indications, 5 under review, and 21 registration trials. So PD-1 inhibitor, tislelizumab, it binds to unique epitopes that we have discussed on PD-1, and this binding orientation differs to that of pembrolizumab and nivolumab. The binding surface of tislelizumab on PD-1 overlapped largely with that of PDL1, leading to almost complete blockade, almost 99% or more blockade of the interaction between PD-1 and PDL1. Whereas in the preclinical studies, pembrolizumab and nivolumab have shown around 80 to 81% blockade versus around 99% or more for tislelizumab. So once the T cells are activated by the binding of the T cell receptor to the MHC antigen complex on the antigen presenting cells or tumor cells, there is upregulation of PDL1 expression to turn off this particular response. So blocking PD1 and PDL1 actually activates the T cells and makes them move into the tumor and microenvironment and cause tumor cytotoxicity. Now, once we are on the right hand side, if you see, this is the T cell and this is the tumor cell. So once we see that the PD1, which is present on the T cell, we are blocking that with the antibody like tislelizumab or any other immunotherapy. The other end of the monoclonal antibody binds to the Fc gamma receptors on the macrophages. This is the normal functioning of any monoclonal antibody. Once it goes and binds to the particular antigen, the other end of the antibody binds to the Fc gamma receptors on macrophages. And these macrophages, as we can see here, can come engulf the T cell and even kill the particular T cell where the monoclonal antibody is bound to. Now, this theoretically should reduce the number of effector T cells present in the tumor microenvironment. So tislelizumab is also slightly different from other PD-1 inhibitors, where there is only minimal binding of this anti-PD-1 to Fc gamma receptors, and it abrogates this antibody-dependent cellular cytotoxicity or T cell clearance. So more number of T cells are present in the tumor microenvironment. Apart from this, the half-life is 30 to 80-fold longer than that of pembrolizumab and nivolumab, and the minimum inhibitory concentration, or rather the IC50, the IC50 values of pembrolizumab and nivolumab are 1.3 to 3.5 times higher compared to tislelizumab, showing that tislelizumab is a little more potent compared to the other agents that we know of. So moving on from preclinical to direct clinical evidence. So as we had discussed, lung, NSCLC, both squamous and small cell, there is evidence, and also in esophageal squamous cell carcinoma in the first line and second line, and gastric cancer are where we have the approval indications even in our country. So today we'll be talking about mainly the esophageal squamous cell carcinomas and what data is there to back our usage. So squamous cell carcinoma of the esophagus, as we know, is one of the top 3 cancers in our country with a very high mortality and quite a difficult cancer to manage in the clinic. So the mortality is much higher in women compared to in men compared to women, and 85% of them are squamous cell and 15% being mainly at the GE junction being adenocarcinomas. The 5-year overall survival rate is only around 20%, which falls to 6% or less in patients who have advanced disease. So squamous is 85% of all esophageal cancers, mainly seen in the upper middle third of the esophagus and in younger patients, and carries with it a very poor prognosis, as most of us know. Adenocarcinoma is around 12 to 14%, located in the lower third of the esophagus, seen in older patients, and It does carry a poor prognosis, but squamous has a worse prognosis in almost all tumor sites compared to adenocarcinomas. So that brings us to the RATIONALE 306 study, where tislelizumab plus chemotherapy was compared with chemotherapy plus placebo in the first line setting for advanced or metastatic esophageal squamous cell carcinoma. This trial enrolled around 650 patients from 162 sites and 16 countries. Therefore, it is a well conducted study where patients were included from many countries and they were satisfying the ethnic diversity that we see in many cancers. So here, newly diagnosed stage 4, no prior disease, and patients were randomized to tislelizumab plus investigator chosen chemotherapy. There were two options given. One was platinum plus 5-FU, or option B, what we commonly use in the clinic, platinum plus a taxane like paclitaxel. This was compared to chemo plus placebo. So patients were initially stratified based on the TAP score of more than 10% or the TAP score of less than 10%. We have enough data to say that we need not switch to doing TAP scoring while using tislelizumab. Just our scoring of PDL1 by whichever platform we are using has high concordance even when we are comparing it to the TAP score. The primary endpoint here was the gold standard overall survival in the all randomized patients, and secondary was PFS response rates and PDL1 more than 10%. What was their overall survival was the other secondary endpoint. So as we can clearly see in the intention to treat population, we can see a definite separation of the curves, which is maintained. And at almost 2 years also, we can see the median overall survival was 17.2 versus 10.6 months, showing a 6.6 months delta in terms of the overall survival. The hazard ratio was 0.66 and the confidence interval was 0.54 to 0.80. So the primary endpoint was hence met. The 18-month overall survival rate was 34 versus 48.6%. So statistically significant and definitely, as per the Kaplan-Meier curves here, clinically meaningful. Now, moving on to this other secondary endpoint of PFS, even that, as we can see here on the left-hand side, there is a clear separation of the curves. At 12 months, the PFS rate is double at 30% versus 15.7% with a good hazard ratio of 0.62. The overall response rates were 65 versus 42%, showing that chemo plus tislelizumab has a better response rate, and the duration of response was also longer in the combination arm. With chemo plus immuno, I think we have all learned what to look for in terms of the IRAEs, and early detection and prompt management definitely keeps the quality of life intact and does not differ from using chemotherapy alone by a lot of parameters. So moving on to the second line setting. So we finished upfront esophageal squamous cell carcinoma. In the second line setting here, tislelizumab was tried as a single agent versus investigator chosen chemotherapy in squamous cell carcinoma. Again, the stratification was based on the TAP more than 10 and less than 10. The primary endpoint here again was overall survival, with all randomized is the primary and secondary being in patients with a TAP of more than 10%. Here again, if it was missed in the first line setting, in the second line setting, the 1 year overall survival is 37 versus 23.7% with the usage of tislelizumab, and the median overall survival showed a delta of nearly 3 months with a good hazard ratio of 0.7. This only gets much better if you're picking up people with a PDL1 of more than 10%. The hazard drops to 0.54 and the median overall survival is close to a year at 10.3 versus 6.8. So even in the second line setting, there's a definite benefit of using tislelizumab as a monotherapy. We know there is a drop off of almost 30 to 40% of the patients from the first line to the second line. So such patients where performance status prohibits us from using chemo plus IO in the second line setting, single agent tislelizumab has shown statistically significant benefit and is approved for usage in the second line setting as a single agent. So here we can see the PFS Kaplan-Meier curves begin to separate approximately 3 months after randomization in favor of tislelizumab. And a single agent tislelizumab definitely had a better overall response rate compared to even chemotherapy, which is usually not the case. Chemo has better responses, but here single agent tislelizumab had much better response rate, showing the efficacy of the drug. There were no new safety signals seen in terms of the adverse events. So though cross-trial comparison is not allowed, if we just briefly go through what all trials are there in this particular setting of esophageal squamous cell carcinoma, on the left-hand side, we can see we have a combination of Pembro, Nivo, even toripalimab and tislelizumab. And the median PFS of tislelizumab and the overall survival of tislelizumab is in line with what we see with other agents, if not slightly superior hazards are seen with the combination of chemo plus tislelizumab. So in the second line setting, also there is approval for other IOs. And even when we do a brief overview of all the trials that we have with us, tislelizumab is in line with the other available immunotherapy agents. Moving on from squamous to adeno. So to talk about gastric cancer, again, one of the most common cancers in our country and equally high risk of mortality in our patients. So gastric cancer here again, we know it is intestinal and diffuse, and the RATIONALE 305 was the study which used a combination of tislelizumab plus capecitabine and oxaliplatin or cisplatin 5-FU in the first line setting compared to just chemotherapy alone. The primary endpoint here again was OS in PD-L1 score more than 5% and in intention to treat analysis set. The secondary endpoint were multiple, like overall response rates and PFS. So the treatment here was continued until progression. The trial was well balanced, almost 500 patients in each arm and good representation from different countries. And most of the patients had CS stomach and 20% of them represented the GE junction disease. And even PD-L1 less than 5 and more than 5 were almost well balanced between the two arms. So on the left-hand side, if you see the overall survival in the intention to treat population, here we see it is a positive data set. Median OS was 15 versus 12.9 months with a hazard of 0.79. And if you dive deeper and look at PD-L1 more than 5%, which was there in almost 50% of the patients, the median overall survival increases to 16.4 versus 12.8 with a hazard of 0.71. So even the PFS rates are nearly double at 2 years at 17 versus 9.1, and the response rates were definitely better with the combination arm compared to chemotherapy alone. The adverse events were again no new safety signals, were well tolerated and well manageable rather is what I would say. Here, if you look at other trials that we have in this setting, so we do have Pembro and Nivo in this particular setting, and the median PFS was very similar compared to all the three agents. And the median overall survival again is almost equal when we look at the other agents available in this setting. So whether it is esophageal squamous cell carcinoma or gastric cancer or GE junction cancers, we do have good data for the usage of tislelizumab, and that is reflected in our NCCN guidelines. It's a category 1 preferred regimen for esophageal squamous cell carcinoma in the first line and second line setting, and also a category 1 preferred regimen in the gastric cancer first line setting. Apart from this, we also know it has other indications which we saw in the initial part of the presentation. So to summarize, so there are good trials which have shown statistically significant benefit in the first line esophageal squamous cell, second line esophageal squamous cell as a single agent, and in first line gastric cancer or GE junction cancers with a combination of either chemo plus tislelizumab or tislelizumab alone. So that would be my last slide. Thank you, and back to the organizers.
Thank you so much, Dr. Sai Vivek, for the excellent talk. Then now we move on to our next session. I would like to invite Dr. Srinivas BJ. He's consultant medical oncology, HCG, Bengaluru. Over to you, sir.
Thank you. Just I will share my slides. My slide is visible now.
Yes, sir. Sir, make it full screen.
Yeah. So thanks. I would like to thank our Dr. Tipeswar Ravi and the organizers and Roche for giving this opportunity to share the experiences on FESGO. So this is the transform the journey for your HER2 positive early breast cancer patients. So we know this Perjeta, that is Herceptin, has transformed the treatment landscape and is a standard of care patients for HER2 positive breast cancers. That means pertuzumab and the trastuzumab combination definitely in either of the neoadjuvant setting as shown in the NeoSPEAR trial or adjuvant setting, especially early breast cancer at high risk of recurrence and metastatic first-line metastatic breast cancer as per the Cleopatra trial. So there is a definitely the trastuzumab, pertuzumab plus chemotherapy is approved and recognized by the international guidelines as the standard of care patients for HER2 positive breast cancers. So based on this HER2 positive HER2 positive early breast cancer, we have a pertuzumab, trastuzumab plus chemotherapy as a neoadjuvant standard of care and adjuvant standard of care in patients without residual disease after surgery. So this is what we follow. So any patients newly diagnosed HER2 positive breast cancers, if tumor is more than 2 centimeter or node positive, it is chemotherapy with the pertuzumab and trastuzumab combination and then surgery. And if there's a PCR, continue trastuzumab and pertuzumab combination up to 17 to 18 cycles. If there's a residual disease, we change to TDM1. If it is there is no T1 or node negative, then usually we directly go with surgery. And if it is node positive, then combine with pertuzumab, trastuzumab. Otherwise, trastuzumab paclitaxel is the treatment of choice. So this is the algorithm usually we follow in most of the patients. So infusion of the pertuzumab, Perjeta, and Herceptin, that is trastuzumab, is well established, but can present with challenges to patients and healthcare systems. So it may be long infusion and observation time, congestion at the clinic and clinic hospitals, challenge of improving resource utilization, placement and maintenance of indwelling venous access, challenge of venous access in some patients. So definitely it will take almost each drug will take 1 hour infusion, so it will be additional 2 hours for each of the two. I mean, combined both trastuzumab and pertuzumab, and the preparation is long, requires high resource utilization, and venous success is requires at cost, risk of infection, thrombosis, and discomfort. And establishing IV access can be particularly burden in some of the patients where IV access, poor IV access is there. So that is why the solution is the subcutaneous injection of the fixed combination of this the trastuzumab and pertuzumab. So that is Phesgo, which is the first formulation in oncology to combine two monoclonal antibodies, that is pertuzumab, trastuzumab in one vial for subcutaneous injection. So it contains the same antibodies as approved for IV pertuzumab and trastuzumab, but has a different route of administration, and is formulated with recombinant human hyaluronidase to allow subcutaneous administration of higher drug volumes, and is ready to use fixed dose formulation administered by subcutaneous injection in the thigh over approximately 5 to 8 minutes. So this is how usually we give the Phesgo injection. So this mechanism of action of fixed dose combination for subcutaneous use. So this is a two monoclonal antibodies with recombinant human hyaluronidase, which help to cleave the connective tissue and help to penetrate and absorb the drug very effectively. So pertuzumab is designed to work with trastuzumab for a dual HER2 blockade, as we all know. And hyaluronidase is a glycosidase used to increase dispersion and absorption of co-administered drugs when administered subcutaneously. So, the effects of hyaluronidase are reversible, and permeability of subcutaneous tissue is restored within 24 to 48 hours. So this is the phase 3 trial, which is a non-inferiority study for assessing the PK and safety of this pertuzumab trastuzumab combination, fixed drug combination subcutaneous versus IV combination. So we can see here the patients who are eligible locally advanced HER2 positive breast cancer with primary tumor more than 2 centimeter or not positive. So they have either the IV formulation or the subcutaneous formulation, and dose dense versus AC was also done in these trials. So primary endpoint being the non-inferiority of the cycle 7, pre-dose cycle 8 in the serum, and key secondary endpoint being the non-inferiority of the cycle 7, pre-dose cycle 8, the trastuzumab serum concentration, and the pathological complete response rate, safety, IDFS, EFS, or other secondary endpoints. So mainly the non-inferiority, especially PK, PD sampling was done to see whether it has the same biological concentration of the drug when given by the IP subcutaneous formulation. So as per this trial, the pertuzumab serum concentration is non-inferior to the IV concentration, and even the secondary endpoint for trastuzumab in the serum is almost equivalent to the IV formulation. So lower limit of 90% confidence interval for serum CTRF and the trastuzumab serum CTRF were exceeded the non-inferiority margin of 0.8. So they achieved the basic primary endpoint of non-inferiority study, that they are equivalent to the PK/PD sampling, or the concentration is almost equivalent to IV formulation. So this is the pathological complete response rate in the subcutaneous fixed dose combination is equivalent to IV formulation of individual drug. So we can see here the red one is the IV pathological complete response rate, and the green one is the fixed dose pertuzumab and trastuzumab combination. So it's almost equivalent. And so this is in keeping with the intended population from previous studies of IV formulation plus chemotherapy in the neoadjuvant setting. So safety profile was also comparable to the IV formulation, with no new safety signals as per this study. Grade 3 adverse events, serious adverse events we are not able to see in this the IV formulation. I mean, in this subcutaneous fixed formulation. And even the adverse events were well balanced between the two arms: alopecia, nausea, diarrhea, anemia, and asthenia. And new safety signals were not there. And incidence of adverse event of interest, including cardiac dysfunction and hypersensitivity, was comparable between the treatment arms. So we can see here the diarrhea, component is almost same. And neutropenia is because of the chemotherapy. There is no impact on the fixed drug combination. Cardiac dysfunction is also not increased because of the subcutaneous formulation. And other side effects were similar in the both IV and fixed drug combination. So this fixed drug combination with trastuzumab and pertuzumab, that is Phesgo, showed non-inferior PK compared to the IV formulation with comparable effectiveness and the safety profile. So that is what this trial has shown. So this is the phase 2 study assessing the patient preference. So patient quality of life, patient preference for whether IV formulation or the subcutaneous formulation was done with some of the preset questionnaires. And here also the most of the patients preferred the very are fairly strong for the majority of the patient. 93% of them were very confident or comfortable with the subcutaneous formulation. Main reason for subcutaneous preference: less time in clinic, more comfortable during administration, and 87% choose this fixed dose combination subcutaneous to continue the treatment. So most patients were very satisfied or satisfied with the fixed dose combination compared to the IV formulation. That is 68% in IV formulation compared to 88% in the subcutaneous formulation. So majority of healthcare physician also felt that switching from IV to subcutaneous would save time and resources in terms of drug preparation, time, treatment, room occupation time for that particular patient, because it takes 2 hours and hardly it will take 10 minutes for this the Phesgo injection. So 88% of the physician felt that it is a quickest to administer and prepare and complete, and required less resource usage for preparation and administration. And 70% of them agreed that this is a more effective way of administering the drug. So 85% of the patient preferred the fixed dose combination compared to 14% preferred compared to the IV formulation. So main reasons for the less time in clinic, more comfortable during administration, and no new safety signals compared to the IV formulation. So this is the phase 3 study of time and resource utilization also has been done. And here also they have some primary objective was time saving for patients and healthcare physician in cycle 5 to 7 and cycle 2 to 4. And we can see here, so the blue, the sky blue bars are the one with subcutaneous infusion. And they have seen that it took only 40 hours compared to 130 and 160 hours with the trastuzumab or combination of IV and IV trastuzumab and pertuzumab combination. And even active healthcare physician time per cycle also is improved, or it is less utilization of time, 9.6 hours compared to 11.6 hours or 14 hours in patients with IV formulation. So time also is saved, and the patient occupation of that particular bed is also saved, 8 to 10 minutes compared to 2 to 3 hours the patient goes on with IV formulation. So significantly reduce the resource utilization with Phesgo versus the IV formulation, and safety was consistent with the previous reports. So preliminary safety results were 2 grades of diarrhea and drugs episode was seen, and 1 grade decreased LVF was seen in these patients. So summarizing, Phesgo treatment resulted in significant time savings for patients with healthcare physician compared with IV preparation. Use of several medical consumables was reduced with Phesgo compared with other treatments in the study. Drug waste in reconstitution of vials was avoided with Phesgo and subcutaneous formulation. Preliminary safety data indicated. Preliminary safety data indicated the study treatments were well tolerated and consistent with known safety profiles. For dual HER2 blockade, advantages are gained from subcutaneous versus IV administration are in addition to those from a fixed dose combination. Taken together, the effectiveness and safety patient preference data for Phesgo versus the IV formulation results from the PHA TIMA further support the use of Phesgo versus IV formulation for the treatment of HER2-positive breast cancer. I think with this, I will conclude. Any questions we can take up?
Sir, I think we can move to our next session. Thank you so much, sir. Thank you for the talk. Now I would like to welcome Dr. Ravi T for the next session. Over to you, sir.
Yeah, thank you, madam. And let me
And
share.
this session is sponsored by AstraZeneca.
Let me share the screen. Yeah, I hope my screen is visible, right? Yeah.
Yes, sir.
Yeah, thank you, and I thank AstraZeneca for giving this opportunity. So we will discuss the transforming patient outcomes with innovative therapy in advanced unresectable HCC. So as we all know, liver cancer is the seventh most common cancer and fourth most frequent cause of cancer-related death globally. So what happens is, in majority of the cases, when we diagnose it, they present in a very advanced stage. So if we see your statistics, about 45% of the time, HCC diagnosis is metastatic. And if we see the survival by stage, localized, at least we have got some decent survival. But if we see the metastasis, especially distant metastasis, the survival is very dismal. So coming to the Indian scenario, in India, liver cancer is the 11th most common cancer type and 8th most common cancer-related deaths. And if we see, especially in males, so it is a very common cancer. What we see. This is according to the Globocon 2022. So coming to the etiology of liver cancer, basically they are all because of inflammation. So any chronic infection, metabolic syndrome, alcohol abuse, they all cause inflammation and which leads to fibrosis, cirrhosis, and eventually the malignancy. So it is basically a deregulated immune network because of the inflammation. So if we see the risk factors, generally in India and even in Western countries, common cause is the metabolic, that is the NASH related what we call. The other scenario is the viral etiology, and as we all know, habits, that is the alcohol and some autoimmune hepatitis, they all can cause inflammation and leading to HCC. But mainly it is the metabolic cause which is very important. If we see the etiology in HCC in India, so basically the NASH, which has overtaken the viral etiology, and then the third is the alcohol related. So if we see the management of advanced unresectable HCC, we can classify the management into early stage, intermediate stage, and advanced stage. And this session we will concentrate mainly in the advanced stage. So we have got various systemic options. In the first line, we have got IO combination, IO VEGF combination, and the second line we have got TKI, ramucirumab, and the third line also some TKIs. So how to choose? So if we see the evolution in HCC, in 2007 we got sorafenib. Previous to that, we used to give chemotherapy where the survival was very dismal. Then came almost a decade, sorafenib was a standard treatment of choice. Later, we got regorafenib, lenvatinib, and from 2018, the era of immunotherapy started. And 2020, the breakthrough was with atezobev, and 2022 we have got breakthrough with durvatremi. So coming to the evidence, see, based on the SHARP trial and REFLECT trial, two TKIs were approved. One was sorafenib, and the other was lenvatinib. In the SHARP trial, sorafenib was compared to placebo, and in the REFLECT trial, lenvatinib was compared to the sorafenib. And both were positive trials, and they achieved the OS benefit. But if you see the magnitude of benefit, it was very modest, and they had got significant side effects. So there was a large unmet need. That's how this unmet need was met with the onset of IOs. So if you see the IM Brave 150, this was the atezobev landmark approval. So it is a phase 3 study evaluating atezobev versus sorafenib in the first line advanced unresectable HCC. Coming to the inclusion criteria, they were all locally advanced or metastatic unresectable HCC, and no prior systemic therapy were allowed. That means it was in the first line setting. Major stratification factors of importance were these vascular invasion and extrahepatic spread and alpha fetoprotein, whether it's below 400 or above 400. It was a pretty straightforward randomization of 2:1. Atezobev was compared with the sorafenib, which was the standard treatment of choice at that point of time. The primary endpoint of the study was overall survival, and the secondary endpoint was objective response rates. So coming to the results, so it was a positive study. We can clearly see that atezobev combination showed improvement in the median overall survival and median PFS in the first line setting. So if we see the magnitude of benefit in the overall survival, the median overall survival in the study was 19 months as compared to 13 months with the sorafenib, and the median PFS of 6.9 months as compared to 4.3 months. So generally in immunotherapy, we all know that PFS is, though here it's a positive study, it is a OS which we are all interested, and atezobev was a positive study in terms of overall survival. So in the subgroup analysis for overall survival, atezobev did not show significant improvement in the non-viral subgroup. So this was one more unmet need. But otherwise, this was one of the good regimen in terms of safety and toxicity. Majority were well tolerated, but the common side effects, what was depicted in the study was hypertension and proteinuria, which we also see in our practice. And the other significant disadvantage was those people who had varices. Since here we are using bevacizumab, it was one of the relative contraindication. So then came the era of dual checkpoint inhibition, that is the IO-IO combination. So what is the rationale for combining dual IO inhibitors? So if we see the anti-CTLA4 and the anti-PD-1 combination, so when we combine and give it, it becomes a synergistic anti-tumor activity. So tremelimumab, which is a CTLA-4 blockade drug, it blocks the CTLA-4, allowing T cell activation. And durvalumab, which is a PDL1 blockade IO, it blocks the PDL1 and reversing the T cell exhaustion. So both act synergistically, which stimulate the required T cells at the microenvironment of the tumor site. And we all know that a single priming dose of Tremi with Durva improves the immune-mediated clinical activity. So before this study, there were a lot of phase 1, phase 2 studies which showed that single dose Tremi will significantly enhance the further magnitude of benefit of durvalumab. So this was the phase 2 study which evaluated the combination of Tremi and Durva in first line setting of HCC. Here the straight regimen also was included, and the primary endpoint of this phase 2 study was the safety. So in this phase 2 study, the straight regimen showed the highest efficacy as compared to Durva or Tremi monotherapy. So the longest median overall survival was observed in the STRIDE study. The median overall survival was 3 months longer than all other treatment arms. And the safety of the regimen also was confirmed in this study. So then come the landmark study of Himalaya, which is again a phase 3 study. It is a phase 3 randomized open label multicenter study of Tremi and Durva in the first line setting of unresectable HCC. So the Himalaya evaluated Durva with or without Tremi versus sorafenib in the first line unresectable HCC. It was a open label global phase 3 study. If you see the inclusion criteria, so patients aged above 18 years with unresectable HCC, BCLC stage B or C, no prior systemic therapy for HCC, and they were all child books class A with good performance status. Stratification was based on the vessel invasion, etiology, and the performance status. Initially, there were 4 arms, but the arm D was removed, and only the 3 arm remained. And the primary endpoint of the study was overall survival. So the STRIDE regimen consists of durvalumab 1500 milligram once in 4 weeks with a single dose of Tremi, and it was compared with the Durva and sorafenib, and the primary endpoint was overall survival. So the STRIDE regimen is a single priming dose of Tremi plus 1 dose of Durva followed by Durva maintenance monthly. So we'll concentrate mainly how this arm did better as compared to the other arms. So coming to the demography and baseline characteristics, it was a well-balanced study. So all the 3 arms had equal representation in terms of viral etiology, performance status, BCLC, PDL1, and the AFP level. And even the second line anti-cancer therapy also, they were all well balanced. So STRIDE demonstrated a significant improvement in median overall survival as compared to sorafenib. So this was a positive study where the OS benefit was demonstrated. So patient who received STRIDE had 22% lesser death risk as compared to patients who were on sorafenib. If we see the median overall survival, Those in the straight regimen, the median OS is 16.4 months as compared to sorafenib of 13.8 months. And we can clearly see a good separation of the curves with almost 10% delta magnitude. So straight improved the overall survival as compared to sorafenib across all the key subgroups. So you take viral etiology also, this regimen had got significant benefit, and other like macrovascular invasion, extrahepatic spread, PD-L1 status, AFP. So across all the subgroups, the straight regimen benefited. And if we see the objective response rate and duration of response, again it is higher for the straight regimen as compared to sorafenib. The median duration of response here is 22 months as compared to sorafenib, which is 18 months. So coming to the safety aspects, the straight regimen was well tolerated as compared to sorafenib with lower rates of adverse events, and especially the grade 3-4 adverse events were significantly less in the straight regimen as compared to sorafenib. And if we see these grade 3-4 immune related events, it is only 12%. And as we all know here, the tremi is only one dose, and it is only the later doses will be durva. So the side effects, even in our practice also, they are all very manageable, and this is relatively a safe regimen to give. The common treatment-related adverse events were rash, pruritus, and diarrhea. But even in this, if we see the grade 3-4, they were very less. So treatment-related hepatic or hemorrhagic events, since there is no VEGF inhibitor here, it was significantly less, and there were no variceal hemorrhage documented in the study. So if we see the NCCN guidelines, what do they recommend? So though we have got various options, see in the first line we have got option of atezobev and durvatremi. Both have been recommended as category 1. And there are other category 1 recommendations also in terms of durvalumab single agent, TKIs, and now we have got category 2B recommendation for Pembro and Tisley also. And in the later lines, we have got options, especially TKIs, cabozantinib, regorafenib, and dual immuno like Ipinivo. And there are certain options useful in specific circumstances, especially in the later lines. If the alpha fetoprotein level is high, we can use ramucirumab. If it is DMMR or MSI high, we can use single agent nivolumab, dostarlimab, and we do nowadays genomics commonly. And if you find any RET gene fusion positive, we have got selpercatinib. So in the present scenario, actually, it is good because as a clinician, we want various options. But how to choose in the first line becomes very important. Generally what we do in our practice is always assess one is the etiology, whether it is viral or non-viral. The other is the varices, especially if the patient has varices, then automatically we cannot give bevacizumab. So atezobev will become a less preferred option as compared to the durva and tremi arm. Coming to the single agent durva, generally we prefer the standard stride regimen because we all know that it has shown the maximum OS benefit. It is a very doable regimen. In our own practice, we have got many patients where we have given this durva and tremi. The common side effects, what we saw in our practice was again some skin toxicities like itching, minor skin rash. Otherwise, we have not seen any major organ toxicities or any grade 3-4 adverse events, and we have not seen any mortality with this regimen because of the side effects. So especially the real world scenario it depicts whatever is there in the clinical study. And one more thing which I want to highlight here in this regimen was coming to the overall survival. If we see initially the curve overlap, so always we should not assess the study based on the initial results. So we should always look at the tail of the curve. So as we all know, these IO regimens, the curves usually separate at a later point, and clearly we can see here the curves beautifully separating, and there is flattening. This flattening always suggests that a small percentage of patients will be there. We will get very long term durable benefit in terms of responses, and a small percentage will go into CR also, and we expect a small percentage of cure also. So given a choice among the various regimens, as I discussed, always look at the child pox status, the varices, etiology, and the current regimens preferred are durvatremi and bev-atezo. So how to choose between these two I discussed based on especially the varices and the viral etiology. So to conclude, HCC is one of the topmost common cancers affecting Indians. There is a shift from viral to non-viral etiology, that is the NASH, responsible for more HCC in the current era. Immunotherapy combination have shown better anti-tumor activity than TKIs alone. Atezobev is one of the standard of care in advanced HCC. The STRIDE regimen, that is the single tremi 300 plus durvalumab, improved the overall survival versus sorafenib, and this regimen has demonstrated an unprecedented 3-year overall survival benefit. STRIDE seems to benefit across all the subgroups, including the non-viral etiology patient population. So this regimen is well tolerated, which has got a low rate of discontinuation and GI hemorrhage. So STRIDE and Durva monotherapy represents a potential new treatment options for patients with unresectable HCC. So thank you for the patient hearing.
Thank you for the session, sir. Now the next session is also by you. It's the sponsored session by Roche.
Sure, madam. I'll just share the slide. I hope the slides are visible.
Yes, sir, it is visible.
So thank you all, and good evening, and I thank Roche for giving this opportunity. So we will discuss how Tecentriq subcute has improved in the management of lung cancer, especially the NSCLC, and how this subcutaneous approach has made a patient's life easy with good improvement in the quality of life. And even from the hospital perspective, doctor's perspective, how this innovation has improved, and why this regimen is a go-to regimen in our present practice. So these are my disclaimers. So if we see the Tecentriq subcute, so the study was conducted in 2 parts, and these are the approval timelines. So initially, there was a small part 1, part 2 of phase 1 study, followed by the phase 3 study, and then it was continued for the phase 3 study. This was the IMBRAVE subcute 001 study, and then came the IMBRAVE subcute 002 study, where again the subcute how it came to the guidelines was studied. So it was launched in UK in 2023, and we got EMA approval in 2024. And now in 2025 January, we have got the DCGI approval. So this Iambrave subcute ion 001, it's a very important study because based on the pharmacokinetic profile, the Tecentriq subcute was approved. So it is the first PDL1 subcute now approved in India. So how the subcute formulation was made? So if we see the addition of this RHU pH 20 temporarily and locally degrades the hyaluronidase at the injection site, but it doesn't alter the structure and the function. So basically, it's the recombinant human hyaluronidase. It's a novel excipient with a very short half-life, and this engineered so that after subcute administration, within 1 or 2 days, the architecture of the skin is reformed and the rapid clearance of the hyaluronidase will occur. And the benefit is ease of administration, that is subcute, and the efficacy will remain the same. So this we will see how in this study it has concluded. So coming to the study design, it was in two parts, phase 1B and phase 3. It was a global multi-center randomized study. It was an open label study conducted in two parts. Phase 1B was the dose finding study and phase 3 was randomized non-inferiority study. The phase 3 investigated the pharmacokinetics, efficacy, immunogenicity and safety of subcute Tecentriq versus IV Tecentriq in the second line setting of locally advanced or metastatic lung cancer. The inclusion criteria, if you see, they are all histologically confirmed stage 3B and 4 lung cancer, immunotherapy naive, failed in the first line platinum based chemotherapy with good performance status. It was a 2:1 randomization. One arm received the Tecentriq subcute. It is a fixed dose of 1875 milligram once in 3 weeks, which was compared with the IV Tecentriq of 1200 milligram 3 weekly. And the primary endpoint, there were co-primary endpoints. The cycle 1 observed the trough level and the model predicted AUC from 0 to 21 days. And the secondary endpoint studied about the safety, efficacy, and the immunogenicity. So if we see the results, the PK parameters, which was especially important in the part 1 of the study, the PK endpoints are a key focus in the part 1, which is used to assess the bioequivalence. We can clearly see here, IV versus subcute, the study met its primary endpoint and the bioequivalence was confirmed. So the first part met its primary endpoint of non-inferiority, and even the co-primary endpoint of AUC 0 to 21 days was met, which is again non-inferior. So the exposure of Tecentriq subcute was consistent with those observed with IV across all the approved indication. If we see the systemic drug exposure following Tecentriq subcute was consistent with that of the former approved other IV clinical studies and support the use of other approved indication. So the Tecentriq subcute and IV had comparable efficacy profile. If we see the median overall survival, the study met its again endpoint. It was non-inferior systemic exposure related in similar efficacy for both routes of administration. So the subcute and IV, it was similar. So again, the result was met, the median overall survival. So subcut and IV had comparable efficacy profile. If you see the median PFS and objective response rates, the curves clearly overlap, which again gives us confidence that the subcut is equivalent to IV. And if we see the benefit again, the delta, if we see, actually it is better in the subcut as compared to IV. Compared to the safety profile, if we see the number of injection site reactions are very low. Most of the toxicities were grade 1 or grade 2 and they are not severe. No infusion related reactions were reported in the subcut arm and no new or unexpected safety signals were identified. The median administration time was 7 minutes for Tecentriq subcut and it was 40 minutes in the IV arm. So majority of the patient, that is 76%, received subcut at an average injection time of only 4 and 8 minutes. So based on this study, the next IM subcut IN002 was conducted, which is basically the patient reported preference for Tecentriq subcut. If we say approximately 8 out of 10 patients choose Tecentriq subcut and 79% of the patients choose to complete their treatment with subcut over the IV. So this was the study design. It was a phase 2 open label crossover study of Tecentriq subcut versus IV, again in PD-L1 positive NSCLC. The inclusion criteria were they were all above 18 years with good performance status. EGFR and all should be wild. Resected stage 2B and 3B lung cancers who completed adjuvant chemo and PD-L1 should be positive, and stage 4 NSCLC with PD-L1 high. So they were stratified based on the stage, type of surgery, and it was a 1:1 randomization. And this is a crossover design. 3 cycles, patient received subcut, the same patient received IV in the next 3 cycles. And then at the end of 6 cycles, the patients were given a choice which one to choose, and it was continued. The primary endpoint was proportion of patients who preferred subcut versus IV at cycle 6, day 1, as assessed by the patient preference questionnaire. And the key secondary endpoint was patient reported satisfaction, choice of treatment, safety. If we see the demographics and baseline characteristics, it was well matched. And especially if we see the disease burden, whether in the adjuvant or metastatic setting, PDL1, so it is a very well conducted study. Coming to the results, so it was a positive study. The primary endpoint was met. So patient preferred administration method was used, assessed by the questionnaire. And majority of the patients, that is 70%, preferred subcut. The main reason was required less time at the clinic, more comfortable, and less emotionally distressed. And again, patient satisfaction assessed with the questionnaire. Over 85% of the patients were satisfied or very satisfied in the subcut arm. So the overall safety profile was consistent with the established Tecentriq safety profile, and no new safety concerns were identified. Eight out of 10 patients choose subcut over the IV to complete their treatment, and all patients who preferred Tecentriq subcut remained in the subcut arm only because they were all very satisfied. So this was the main reason why patients preferred subcut. It required less time in the clinic, feels more comfortable, and less emotionally distressing. So these were the from the patient perspective. Coming to the healthcare perspective, reported outcomes. Physicians also felt that it was the most convenient method of administration of Atezo. They also preferred subcut versus IV. The healthcare perception also because of the ease of administration. So majority preferred subcut. So coming to switching between subcut and IV, again it was well tolerated. The overall safety profile, that is crossover and continuation, was consistent with the established Atezo safety profile. No new safety concerns were identified. Switching between Atezo subcut and IV, regardless of the sequence, was very well tolerated. And the likelihood of a patient experiencing injection site reaction or infusion reaction did not increase when we switch from subcut and IV or vice versa. So whenever we want to give IO, that is Atezo, I think subcut is preferred over IV because of the reasons I mentioned. Now we can always give this advantage to our patients where approved, that is Tecentriq has been approved as monotherapy in lung cancer metastatic setting, NSCLC with PD-L1 above 50% based on the IM power 110. In metastatic NSCLC patients progressed on prior chemotherapy, and in the adjuvant NSCLC patients with PD-L1 more than 1%. So Tecentriq subcut is the treatment of choice. In first-line metastatic NSCLC, based on the IM power 110, if the PD-L1 is high, it has shown the OS benefit and favorable safety profile. So this was one chemo-free regimen which we commonly use in our scenario. So based on the WOK2 study previously treated NSCLC, it can be used in second line and third line, PD-L1 unselected. There is again OS benefit as compared to chemotherapy. Again, one of the few trials of IO which shows single agent IO beneficial over the chemotherapy in the second line and third line setting. Coming to IM power 010 in adjuvant setting, post platinum based chemotherapy and surgery, again Tecentriq subcut has got DFS benefit, especially in PD-L1 above 1%. So Tecentriq delivers survival benefit across the NSCL journey from curative intent adjuvant therapy to durable control in the advanced disease setting. If we see this in IM power 110, first line Tecentriq monotherapy significantly improved the OS, especially in patients with PD-L1 high setting. Tecentriq demonstrated 40% reduction in the risk of death as compared to chemotherapy. At 1 year, 2 out of 3 patients treated with Tecentriq monotherapy were alive. And if we see the final OS results with patients with PD-L1 high NSCLC, clearly we can see here 20.2 months benefit of OS as compared to 13.3 months in the chemotherapy arm. So it is highly significant. And in the exploratory analysis with a median follow-up of 2.55 years, the benefit was maintained in this subset of population. If we see in the WOK, the second line Tecentriq reduced the risk of death by 22% in the metastatic NSCLC patients. So there was 22% reduction in the risk of death of Tecentriq as compared to the docetaxel chemotherapy. Clearly, we can see the survival at the end of 4 years. We can see the tail of the curve, which is separating very widely. Again, which gives the confidence that a significant number of patients benefit in a very durable benefit. Coming to the IM power 010, where adjuvant Tecentriq nearly doubles the disease-free survival. We can clearly see here in the landmark study of this adjuvant setting in the PD-L1 positive patients, there is both DFS and OS benefit. And we can clearly see the hazard ratio of 0.7 in the OS, which is highly significant. And the DFS, even at the end of 5 years, is statistically significant. So in the stage 2 and 3A PD-L1 positive patients, the median DFS in the Tecentriq arm was 30 months longer as compared to the supportive care arm. And the median OS has still not yet reached at the 5 years. So coming to the economy, as we all know, whenever we give subcut, the time taken will be very less. It is only about 4 to 5 minutes as compared to half an hour to 1 hour in the IV. Handling is very easy, so it doesn't require any dilution. IV is always a complexity. Preparation, loading, there will be a chance of infection, which will not be there in the subcut. Flexibility is also very easy. So once in 21 days, a fixed dose of 1875 milligram subcut we can give within 7 minutes for the first and subsequent injections, as compared to IV, which requires about an hour infusion. So the positive impact of subcut formulation is very much appreciated, especially in the resource limited setting as of ours. And it is economically favorable and advantageous also. So this has transformed the way we practice. Now majority of our practice is Tecentriq subcut as compared to the IV because of all these advantages. To summarize, so Tecentriq subcut is the first PDL1 subcut now approved in India with comparable efficacy and safety as compared to IV formulation. 79% of the patients, that is 8 out of 10 patients, prefer subcut. Admission time is less, only 7 minutes as compared to half an hour to 1 hour in IV. The hospital chair time also is less, and majority of physicians also prefer subcut as compared to the IV because of these advantages. So with this, I will conclude and hand over the session to the organizers. Thank you.
Thank you, sir, for the excellent talk. Back-to-back 2 sessions. Thank you so much. Now I would like to invite Dr. Smita Saldana. This session is also sponsored by Roche. Dr. Smita Saldana is consultant medical and hemato-oncologist at HCG Bangalore. Over to you, ma'am.
So can you, thank you. Am I audible?
Yes, ma'am.
Yeah.
Audible.
So let me share my screen. So is it visible in the full screen? So
No,
thank
ma'am.
you. Is it visible on the full screen?
Yes, yes,
Yeah.
yes, ma'am.
So thank you, Dr. Ravi, and thank you, Roche, for this opportunity to discuss about alectinib in non-small cell lung cancer. So we will be basically going through the brief review of non-small cell lung cancer, the methods available for ALK testing in non-small cell lung cancer, a few key important points of ALK positive disease, how they manifest, the approved ALK inhibitors in non-small cell lung cancer, and specifically the data on alectinib. So as we all know, lung cancer is definitely a global health issue. So it's the second most commonly diagnosed cancer and the leading cause of mortality. We almost see 2.2 million cases per year and almost 1.8 million deaths. And it is a heterogeneous disease. So we know adenocarcinoma is the most common form of lung cancer, followed by small cell lung cancer, that is 13.3%. In adenocarcinoma, it is almost 52%, and we have squamous cell around 27%, and non-small cell around 13%, and the rare subtypes of large cell carcinoma and other specified types. So if you look at the incidence in India, almost we see 72,000 new cases. And if you look at the numbers, almost more than 85% of them, we are seeing mortality per year because of lung cancer. And if you look at in men, it is the most common cancer among men, almost 51,000 new cases per year. Now let us look at the ALK testing. So molecular testing is very important in lung cancer and is all of us recommended, and it is done routinely in practice. So the routine testing in clinical practice is done for EGFR mutations and ALK rearrangement. And this is as recommended by all the various guidelines, the ELCC, NCCN, and ESMO. Identifying the molecular profile of a tumor helps us in our clinical decision-making process and also in selecting the tailored therapy for that particular patient. Now, how can we test ALK testing? It can be done by the following few methods. Most commonly, we all follow either the IHC or the FISH method. Sometimes we may do the RT-PCR. And now whenever we are doing a whole molecular panel for the lung, we mostly do the NGS panel. So any of the 4 types are valid testing methods. If you look at the ALK positive disease, it is relatively, the incidence of ALK positive non-small cell lung cancer is uniform across the ethnicities. There is no much difference between the ethnicity. And if you look at Europe, almost we can see the ALK positive almost 3.7%. In the US, you see almost 8%. And in Asians, you're seeing around 3.4%. So roughly, if you have to say, it's around 3 to 5% are ALK positive in the non-small cell lung cancer. Around 75,000 patients are diagnosed, and among them 5% is quite a big number. So the incidence of ALK positive non-small cell lung cancer is higher in patients with non-squamous histology, patients who are never or former smokers, younger patients, females, and patients who do not have EGFR or KRAS mutations. So if you look at the rearrangement of the ALK gene, this is how the ALK rearrangement gene looks like when there's ALK translocation. So the ALK rearrangement results in a structural alteration of the chromosome and the expression of an ALK fusion protein. This was first discovered in 2007 by Soda et al. So in India, if you look at the ALK mutation positivity, it's almost seen a little higher compared to the other Western data. Almost in 7% of lung cancer, we see the ALK mutation. It's found more commonly in the young patients with a history of never or light smoking. But it can vary between 2.7 to 13.2% as per different papers. Now, what are the currently approved first-line treatments for advanced ALK-positive non-small cell lung cancer? So we have the first molecule, that is the first generation crizotinib, and it was based on the trial Profile 1014. It was approved in August 2011, and European EMA approval took almost another 4 years. The median PFS was 10.8 months, and the dose is given 250 mg BID. Then we had the Ascent-4 trial, wherein ceritinib came after 6 years in 2017. And I think subsequently together FDA and EMA gave approval for ceritinib. And we definitely knew the PFS improved compared to crizotinib. It was 16.6 months. The dose initially was recommended 750 mg once a day. And now most of us give 450 mg once a day along with food. Then you have the LX trial, the alectinib. So again, the approval came in a few months after the ceritinib approval in 2017 November. And again, EMA also gave approval simultaneously. The PFS almost doubled. So the LX, it showed 34.8 months, and in the Elysia trial, it shows us a median PFS of 41.6 months. The dosing is 600 mg given twice daily. Then we have the brigatinib in 2020, based on the ALTA-1L study. The median PFS was 29.4 months. The dose is 180 mg once daily. Then you have the CROWN trial, wherein the lorlatinib got approval in March 2021. EMA took almost 8 months for the approval. The median PFS is still not achieved, and the dose is 100 mg once daily. So if you look at overall, 100 mg BD. If you look at overall, definitely alectinib, the median PFS is significant. You can see the 41.6 months. It's more than 3 years, 3.5 years. Now, crizotinib demonstrated a significant PFS benefit as per the Profile 1014 study I showed you. It was compared against the median PFS against chemotherapy, standard of care at that point of time. And definitely against standard of care, it was showing more than wide separation of curves and the significant hazard ratio of 0.45. Then if you look at the 4-year overall survival rate, also it showed crizotinib at 56.6% and chemo was around 49%. So there was a benefit in overall survival also in the patients who received crizotinib. If you look at the adverse events, it has a severe adverse events like basically the visual disturbances and GI adverse events. So if you see visual disturbances almost 73 any grade, and GI disturbance almost ranging from 50 to 60%. So quite significant adverse events. But it did make wonders compared to your chemotherapy in the first line setting when initially it came into use. Then you have the ceritinib. So this was again showed a PFS benefit, 16.6 months versus chemotherapy. Again, the standard of care here is chemotherapy. So 16.6 versus 8.1 months. And the median PFS was similar to that with crizotinib. If you look at the adverse event here, we didn't have visual adverse events. It was more of GI adverse events like diarrhea, nausea, vomiting. Then you have if you look at the GI toxicity regarding the quality of life. So it showed a greater impact on the quality of life with ceritinib versus chemotherapy. The diarrhea, nausea, vomiting was reportedly as worse for ceritinib than chemotherapy. So you can see the incidence of side effects. Diarrhea is as high as 22.1%, whereas no diarrhea in the chemotherapy arm. Similarly, nausea, vomiting also was significantly higher in the ceritinib arm versus chemotherapy. The other thing is the drugs usually enter the brain by crossing the blood-brain barrier. So crizotinib is a substrate for P-glycoprotein, and ceritinib is a substrate for both P-glycoprotein and the BCRP. These are drug efflux transporter proteins. So therefore, they eject the drugs out of the blood-brain barrier. Therefore, the penetration into the CNS or the CNS control was not very good with the crizotinib and ceritinib, though they are small molecules. So therefore, it made the CNS a sanctuary site for tumor growth when specifically are using crizotinib or ceritinib. Now, if you look at the brigatinib as per the ALTA-1L study, so the PFS again is significant. Brigatinib was compared to crizotinib. So it was 24 months versus 11 months with a significant p-value of 0.001. And if you look at the 2-year PFS, it was 48 months versus 26 in the crizotinib arm. Now, if you look at the lorlatinib, the median PFS here, you can see it's widely supported as early as 4 months itself. You can see the suppression, and if you look at the suppression, it's such a significant suppression. Again, lorlatinib was compared to the crizotinib. So the median follow-up duration was 60.2 months versus 55.1 months. The median PFS is still not reached in the lorlatinib arm, whereas crizotinib was around 9.1 months. And the maximum PFS, what is seen is almost around 64.3%. And look at the hazard ratio, it is 0.19. And you can see the wide suppression of the Kaplan-Meier curve showing excellent benefit for lorlatinib. Now, if you look at the treatment-related adverse events, that is where lorlatinib scores a little lower. So we are concerned about one is edema, and the other thing is very rarely the psychiatric adverse event, what you can see. And if you look at leading to treatment discontinuation, significant, very high, almost 62% had treatment discontinuation in their lorlatinib arm, whereas only 48% in the crizotinib arm. Permanent discontinuation, drug discontinuation again, leading to around 11%. And treatment-related adverse events, if you see again, much higher in the lorlatinib compared to the crizotinib arm. Now, specifically on the alectinib, the Alecensa study. So the key features are its selectivity, the potency of the molecule, the specific CNS penetration by alectinib, and how it acts in the resistant mutations also, and the safety profile. So there are various phase 2 studies initially, the AF001JP. It was a Japanese study wherein there was 46 patients, which was a phase 2 study where they use alectinib. Then you have the JLX study, again a phase 3 study in Japanese patients, around 207 patients. Then you have the significant global phase 3 study in treatment-naive patients with ALK-positive non-small cell lung cancer, the LX study. And the Alecia study, which was done in the treatment-naive Asian patients with 187 numbers. So if you look at overall, it has a large body of evidence, alectinib, with results in 3 phase 3 trials supporting alectinib as a preferred first-line treatment for patients with previously untreated advanced ALK-positive non-small cell lung cancer. Now let us briefly go through the LX phase 3 study. So it was a stage 3B or stage 4 non-small cell lung cancer were taken into the study. They all had to be ALK positive by IHC test. They should be treatment naive and ECOG performance status of 0 to 2. Totally 303 patients were taken. The stratification factors were based on the CNS mets at baseline, Asian versus non-Asian, ECOG performance 0, 1, 2, 2. And they looked at alectinib 600 mg twice daily versus crizotinib 250 mg twice daily until progression or until toxicity. And the secondary endpoints were response rate, the duration of response, overall survival, and PFS, and the CNS response rate. If you look at the primary analysis as per the data, so it was the cutoff date was on February 2017, and the exploratory analysis final OS data was completed in 28 April 2025. That is last year. If you look at the baseline characteristics, it was well matched compared to both arms. Patients with CNS metastasis almost around 42% were there with CNS metastasis in the alectinib versus around 38% in the crizotinib arm. And prior brain radiation around 17% versus 14%. If you look at Asians, again, well matched, 46 and 45%. And majority, if you look, it is females. Now, if you look at the mature final PFS data, the proven protection from the disease 3 years was nearly 3 years with a 34.8 months freedom from progression. You can see the suppression of curves as early as around 6 months you can see, and it is continuing. The white plateau is continuing with hazard ratio of 0.43, 10.9 months in the crizotinib arm versus 34.8 months in the alectinib arm. So the final PFS analysis showed a mature median PFS of 34.8 months in the first line setting, almost 3 times longer efficacy benefit compared with the crizotinib. If you look at the final PFS event-free rate, again you can see in patients treated with alectinib, there were 43.7% were event-free survival at 4 years compared to crizotinib. Significant number again. If you look at the PFS subgroup again, if you look at this forest plot, almost all factors favors alectinib compared to crizotinib, irrespective of the Asians or non-Asians. And if you specifically look at patients with past smoker or non-smoker, the benefit is much higher for the alectinib compared to crizotinib. Only there in smoking arm, slightly you see that crizotinib is favorable. And the magnitude of PFS treatment effect was seen much more in alectinib compared to crizotinib. If you look at the PFS by the CNS metastasis status, patients with pre-existing CNS mets, the Alecensa, you see 25.4 months median PFS versus 7.4 months in crizotinib, more than 2 years difference. And in patients without pre-existing CNS mets, you can see almost as high as 38.6 months versus 14.8 months, almost more than 3 years PFS. And in a patient of lung cancer with CNS mets, you're getting a 3 years median PFS is excellent.
Ma'am, sorry to interrupt you. Please
Yeah.
conclude the session in next
Yeah.
2 minutes.
So in phase 3, you have CNS progression around 84% reduction versus crizotinib. And the response rate, if you look at crizotinib versus alectinib, you can see again, alectinib is much higher, 42.3 months duration of response. The median duration of response was 42.3 months with alectinib versus 11.1 months with crizotinib. Again, if you look at the CNS progression, the treatment with alectinib significantly reduced the risk of progression. And you can see this forest plot waterfall curve wherein you can see definitely benefit with the alectinib versus crizotinib. So if you look at the 5-year survival rate, alectinib at 62.5% versus crizotinib of 45.5%. And the final overall survival, you can see 59.5% versus 48.1%. So if you look at the side effects also, the side effect profile also, it was relatively safe, except you need to look at the blood bilirubin levels and increased liver functions. Otherwise, relatively, alectinib was a very well tolerated drug. And in conclusion, Alecensa has demonstrated a median PFS of around 34.8 months. In the Elysia, 41.6 months in the first line setting. It protects against CNS metastasis, and it is a well tolerated with a well characterized and manageable safety profile in long-term use. With this, this is the molecular testing and the ESMO guidelines. I conclude the session.
Thank you, ma'am, for the wonderful session. Now I would like to invite Dr. Srinivas KG, Director and Senior Consultant Medical Oncology, Clear Medi Healthcare and Radiant Hospital, Mysore. This session is sponsored by Zydus. Over to you, sir.
Am I audible?
Yes, sir. Yes.
Thank you, Dr. Ravi, and thanks Zydus for giving me this opportunity to talk on this topic, nivolumab in squamous cell head and neck cancer. I would like to share my screen. My slides are visible?
Yes, sir.
Let's see. Okay. So I have been given a task to talk on the role of nivolumab in squamous cell head and neck cancer. So innovation to impact. So if you typically understand nivolumab is available in 40 mg and 100 mg in Zydus. So there are a lot of studies which I'm going to talk about for various doses which we typically use in India. So before going to the specific topic, I would like to highlight upon how Tista was developed in the past 10 years or so before it got launched in India. The journey was not easy. In fact, hats off to the guys, Zydus, who took so much of effort. Though it may be the fifth or sixth biosimilar in their basket, but every time I was interacting with the medical team and the Zydus team a few months back, they were sharing the situation, what exactly before launch, what exactly happens, maybe 8 years or 10 years, how will they go through, what are the challenges they come across before they get the approvals. So doing a biosimilar is not easy. Getting the approvals are not easy. It comes with a great difficulty and challenges. But provided a company has a zeal like Zydus, has a zeal to develop this molecule with so much of passion and dedication, only that is a time when it is possible to develop these kind of molecules in country like India with so much of hurdles and challenges. So typically, if you go back 10 years or 11 years back, if you go back to the time, so there was in 2015, there was a clonal development where they got a permission to carry out the research and development work on similar biologics of nivolumab, typically in September 2015. Then the biosimilar assay begins in 2017. The DBT1 submission happens in June 2019, and they got the tox approval, that is RCGM permission to conduct preclinical toxicity study in April 2020. Then the C5 submission happens in 2021, and they got a no objection certificate from DCGI in September 2022. So after 2022, the DCGI approval, they started the phase 3 clinical trial. It all went up to from September 2022 to February 2024. Then the submission to DCGI happens for a marketing authorization and application to DCGI for the similar biologics of nivolumab in April 2024. Finally, they got NIB approvals, and then the BMS had put the challenge court in the legal this one against Zydus for how these people can develop the molecule. Then the legal journey went from 2021 to 2024 in Madras High Court and Delhi High Court. Finally, they got this over and they launched Tista. It's a very pride moment for Zydus and for us, being an Indian company. They got this product done, and I'm one of the very strong prescriber of Tista currently in my clinical practice. So finally, in Jan 2026, the Tista got launched, and thereon, no looking back, thousands of patients are getting the benefit of Tista. I can say proudly before whatever the nivolumab indication was there, when we used to prescribe Opditab, if you used to give 10 prescriptions, one patient used to say, I will take Opditab. But in today's time, after the launch of Tista, if I give 10 prescriptions, 9 will take Tista prescription without saying anything. They don't face any challenge. One may get say, sir, it's difficult for us to afford. So there is a dramatic change in the acceptance by the community of people like in India, because of challenge becomes a very big, cost becomes a very big challenge. So before I begin my topic, I would like to say thanks at the outset to Zydus for their wonderful effort to bring out this molecule in January 2026. So with that background, I would like to start. What is this Tista? It's a biosimilar nivolumab, contains the same active drug substance like the original molecule innovator. So it contains typically a glycosylated human monoclonal antibody of IgG4 isotope composed of 1308 amino acids expressed in a genetically engineered CHO cells like the reference molecule, and developed with same pharmaceutical composition as the innovator, with an approved strength of 40 mg and 100 mg, and the route of administration is typically intravenous. So as you can see, the left side, the chemical configuration, which is very similar to the innovator molecule. So typically the indications for nivolumab we use a lot for different indications, but one such common indication would be squamous cell carcinoma in head and neck. So nivolumab as a monotherapy is prescribed for the treatment of recurrent or metastatic squamous cell carcinoma of the head and neck in adult patients with disease progression on or after platinum-based therapy. So this is a checkmate 141, which everybody are familiar with. Recurrent or metastatic squamous cell carcinoma of oral cavity, pharynx, and larynx. Progression on or within 6 months of last dose of platinum-based therapy, irrespective of number of prior lines. Probably patient may be heavily pretreated, and documentation of P16 to determine HPV status regardless of PD-L1 status, and the stratification factor was prior cetuximab treatment was given or not. So they were typically randomized in 2:1 fashion. Nivolumab 3 mg per kg, IV 2 weekly, versus investigator of choice, probably a metronomic therapy or methotrexate, a docetaxel, cetuximab, and many options. So the primary endpoint being overall survival, the other endpoints being PFS, overall response rate, safety, and duration of response. So typically, if you see, this is what the beauty of immunotherapy, what it has does past several years in head and neck cancer. The median OS is 7.7 months versus 5.1 months with 0.68 of hazards. The curves get neatly separated as early as 3 months, and it sustains. Ravi was telling in some other, he was talking about hepatocellular carcinoma. You need to look at the tail of the curve. So when you look at the tail of the curve, still that gap is still maintained. The difference is maintained as you go on. Whenever we talk about immunotherapy, it is sustainable. So patients who do typically respond, they respond for quite long, and that is the beauty of immunotherapy. Especially we talk about nivolumab in this context. So in head and neck cancer, so the median OS was prolonged with nivolumab compared with chemotherapy. Of course, not only the OS benefit, look at the quality of life of the patients. I have not seen any challenges. I have given hundreds of patients nivolumab in my clinical practice. Hardly single-digit number of patients do come with some kind of adverse effects. Majority of the time, the journey goes very, very smooth. On the other hand, when we offer them a chemotherapy, they come with myelosuppression, so much of mucositis, asthenia, breathlessness, weakness, tiredness, so many other things patients do come with, and they get admitted for supportive care in our routine practice. I'm sure everyone in the platform would agree, Dr. Ravi, Smita, all those, like anybody for that matter, would agree. When we give chemo, probably the journey, the quality of life is much harsh and much poor when they are on chemotherapy. But on the other hand, when we give immuno, the journey typically goes smooth, and not only the good quality of life, we are also talking about the efficacy. Now we have the OS benefit. So 1 in 6 patients typically alive at 2 years. Patients, the median time to respond was similar between nivolumab and the IC. The survival advantage with nivolumab aligns with enhanced response durability. Again, if you see the curves neatly get separated, improved overall survival independent of PD-L1 status. So whether it is PD-L1 positive or negative, still the survival benefit is seen in both the groups, saying that irrespective of the PD-L1, the nivolumab has a benefit in these subgroup of population. So nivolumab demonstrated 46% of reduction in risk of death if somebody is on this drug. So it significantly reduced the risk of death versus investigator of choice. So if you see the, it was more pronounced, actually the survival advantage was more pronounced in patients without prior cetuximab. So probably the take home message is, if the patient has recurrence or progressed on platinum doublet or platinum based therapy, so without wasting much of time, if you offer them an immunotherapy rather than an anti-EGFR, probably there is a magnitude of benefit may be much higher compared to those patients who have received cetuximab as a prior exposure. So there is a greater survival benefit which was observed with cetuximab naive patients. If you can see the 18-month OS, it is nearly to the tune of 25% versus it was not applicable in investigator of choice. Hazards, look at the hazards, it is 0.52. On the other hand, if the patient is having prior cetuximab, the hazards is 0.84. So definitely the hazard is much impressive in patients, in cetuximab naive patients, suggesting that Nivo would work better in a cetuximab naive patients. Probably patients, if they progress on Nivo, probably then sequencing with later with cetuximab may be an option. So probably, but the first line option would be giving a checkpoint inhibitor. So nivolumab delivered a clinical meaningful survival advantage, improving the median OS. Nearly doubling of median duration of response was consistently maintained at 12, 24, and 36 months versus chemotherapy. Patients achieving a higher CRPR experience a transformational outcome, and patients without prior cetuximab had a better survival outcome, as I showed you in the previous slide. And survival gains were achieved with a favorable tolerability profile. So now it doesn't stop there. So now nivolumab has indicated for various other indications. We were talking about a recurrent or metastatic setting. Now something called a Nivo post-op study, which was tried in adding to a cisplatin and a radiotherapy versus cisplatin radiotherapy alone after surgery. So especially if the patients are having a high risk of relapse, then they started seeing that how about adding a nivolumab along with cisplatin as a concurrent radiochemotherapy option. So this was GOTEC 2018-01 Nivo post-op study, which is again a randomized open label phase 3 trial. So what was the rationale of this study? The post-op radiotherapy plus cisplatin for high-risk resected locally advanced squamous cell carcinoma, though it is a pretty standard of care for more than 2 decades, if the patients are having these adverse risk factors like extracapsular invasion, positive margins, PANI, peripheral, nodal invasion, nodal involvement. So they are some of the typically very high risk features, which we know that in the baseline itself, these are the patients definitely going to relapse in coming years, probably maybe 6 months or a year or 2. So it is said that around 40 to 45% of the patients do relapse within 2 years despite optimal chemoradiation after surgery. And definitely PD-L1 inhibitors are very effective in these recurrent or metastatic setting. We know that these drugs are active in these kind of situation. So then a new post-op trial saw that how about adding the same in a high-risk population much earlier rather than when it happens to be a recurrent or a metastatic situation. So the aim was simply to add nivolumab to a standard post-op cisplatin-based chemoradiotherapy and look for the improvement of DFS. So this is a study design. It's a multicentric international randomized open label phase 3 study. Around 82 centers across 6 European countries, but between the age of 18 to 74 years with good performance status. and patient should have completed the surgery. At least they should have a R0 resection or sometimes R1, depending on the patient. So, and definitely these high-risk pathologies were seen as a extracapsular nodal extension, posterior closed margins, more than 4 involved cervical nodes, and multiple perineural invasions. So the exclusion was nasopharyngeal or seno-nasal thyroid cancers, unknown primary or metastatic disease, R2 resections, prior treatment other than surgery. So these are the patients typically excluded from the study. So typically a very well designed study for a high risk resected squamous cell carcinoma patients. So they were randomized to nivolumab 240 mg as a single dose, followed by concurrent chemoradiation. The nivolumab dose would be 360 mg. Then again, after that radiation, nivolumab 480 mg every 4 weeks for 6 months. So again, the control arm, typically what we generally used to practice, standard post-operative concurrent chemoradiation followed by observation. If we see the study endpoint, the DFS was the primary endpoint, and secondary endpoint was overall survival, safety, and cumulative incidence of local regional relapse or distant metastasis, DFS. So 680 patients were there in this study. Around 341 patients in concurrent chemoradiation, standard chemoradiation, and around 339 patients were for nivolumab cisplatin concurrent chemoradiation. So completed the 650 participants completed the initial treatment phase, and in that 327 patients are in concurrent chemoradiation and 323 patients in nivolumab arm. So radiotherapy delivery, again now high risk PTB dose of 666 grain, 89% of the patients were given in standard chemoradiation arm, 85% of them completed in nivolumab arm. Pretty more or less same kind of situation in both the groups. Now the median cumulative cisplatin dose was comparable between the groups, 280 versus 274, with 80% of participants receiving more than 200 mg per meter square and few switching to carboplatin, which we typically do it in our clinical practice. The goal is to achieve at least 200 mg per meter square, the cumulative dose of cisplatin for the entire journey of therapy. So if you look at the 3-year DFS, cisplatin with radiotherapy had a 52.5% of DFS compared to nivo plus cisplatin radiation. The DFS gone up to 63%, where the p-value is 0.034 and the hazard ratio of 0.76. So adding the nivolumab to adjuvant cisplatin and radiation therapy after surgery improved the DFS for sure, which met the primary endpoint. If you look at the curves, again, it started like as early as 3 months and then got separated, and it is most wider in 24 to 36 months. If you look at the curve, we are talking about
Sir, sorry for the interruption. Kindly conclude in 2 minutes.
Yeah. So if you see the curve, middle part of the curve, 24 or 36 months, the curves get wider, suggesting that I was telling you the relapse recurrence is very higher in less than 2 years. So that was the same time where the curves is getting better and better in nivolumab arm, suggesting that when you give a concurrent nivolumab with cisplatin and radiation, probably the chance of relapse would be lesser. This is what typically it depicts. So if you see the subgroup analysis of DFS, all HRs of disease-free survival events were in favor of nivolumab, cisplatin and radiotherapy. The subgroup analysis across the subgroups showed a benefit. So safety summary, it was not a pretty stormy course. Only grade 5 adverse events were seen in only 2 to 3% of the group. Majority of them were grade 1, grade 2 adverse events, not much. So I will, with that shortage of time, I would like to conclude the post-op trial data, which established a proof of principle that post-operative nivolumab added to standard of care cisplatin and radiotherapy is a way to improve patient outcome for resected high-risk locally advanced squamous cell carcinoma and could be proposed as a new standard of care treatment. So again, low-dose immunotherapy. This was a very popular study in which done in Tata Memorial Hospital. The primary endpoint was being 1 year OS. So typically, nivolumab used in 20 mg flat dose once every 3 weeks versus oral methotrexate and celecoxib and erlotinib, which is what we call it as a metronomic therapy. So 150 patients, 51 patients were randomly assigned to this, 75 patients in TMC and 76 in the TMC arm. So typically, if you see the low dose nivolumab, which led to an improvement in 1 year OS from 16.3% to 43.5%. This was a very dramatic study. Everybody started looking at this study. Whole world actually started looking at this study because low dose immuno was the proof of concept which was brought from India, and it's very proud moment for me to share this data because Tata Memorial Hospital, we being Indians, we showed this to the world that even a low dose immuno can work in this kind of patients. Invention is inevitability is mother of invention. So the cost actually was tempted them to make these kind of studies, and it showed that even a low dose nivolumab can give a substantial benefit in these patients. As you can see, the median OS was 6.7 months versus 10.1 months. The P was very, very significant. So this is a flagship proof of concept that very small dose of nivolumab can deliver the benefit when paired with a rational backbone of metronamic therapy. So again, the adverse events were very, very, very modest in this low dose therapy. So I think in want of time, I would like to summarize post-platinum recurrent metastatic squamous cell head and neck carcinoma. Only nivolumab and pembro have demonstrated the OS benefit was a standard of care. Nivolumab survival benefit was seen independent of PD-L1 expression. So, and cleaner biomarker agnostic narrative. So, first line recurrent metastatic squamous cell carcinoma, pembro dominates a PD-L1 driven tumor, but irrespective of the PD-L1, nivo would do the job. So, in curative intent, again, post-op high-risk patients, nivo is the first IO to show that DFS benefit added to cisplatin as shown in nivo post-op study. So, adding nivo significantly as the DFS improvement with a 24% reduction in recurrence risk. Benefit was seen regardless of PD-L1 again. And as I told you, Tata Memorial study, which is a very popular study, probably remarkable benchmark study in the history of immuno-oncology, low dose nivolumab data. Ultra low dose nivolumab, even as low as 20 mg with metronomic therapy, could give a substantial survival benefit of 1 year OS of 43% versus 16%, showing revolutionizing the way we manage the patients in our day-to-day clinical practice. Again, I would like to say Kishta is available in 40 mg and 100 mg. So I would wish I think with the molecule low dose concept, and again now with the innovate and the biosimilar what we have from Zydus becomes very, very affordable to almost all patients. Even I'm talking about tier 2, tier 3 cities where the patients paying power is very, very less. But given in that situation, I think thanks to Zydus for making this molecule available to our patients. Most of them were very low affordable patients. Still, they can afford these generic molecule. Thank you so much for the time for patient listening.
Thank you so much, sir. Now I would like to invite Dr. Vijay Kumar Srinivala, sir. This session is sponsored by Glenmark. Dr. Vijay sir is Senior Consultant Medical Oncology, Sakra World Hospital, Bengaluru. Over to you, sir.
Hi, thank you. Good evening. Thank you so much for the warm invitation. I'd like to congratulate Ravi sir on this conference and also thank Glenmark for this opportunity. Can I just get the backing team to just get my slides on up and running? So I'm primarily going to be talking more about am I audible? Sorry. Am I audible?
Yes, sir. Yes, sir.
Perfect. So I'm going to be talking about chemo-induced nausea vomiting. So it's about a phase 4 study called MyRisk. Can I just get the slides at the back end, please? Perfect. So thank you. So next slide, please. So this is basically, we're going to be talking about personalizing chemo-induced nausea vomiting prophylaxis. What do we learn from the MyRisk trial? Next slide, please. So basically, we know that these factors have to be individualized. There are multiple factors which are important. In most of the guidelines, have always taken chemotherapeutic drugs as the component, while the patient-specific components have not really given importance to. Next slide, please. So what we mean by patient-specific factors are sometimes, especially patients who are with female sex, so those with younger age group, or those with a personalized history of anxiety, or people with alcohol consumption, or those with motion sickness, or those who've had high risk of emesis during pregnancy, these patients are at a higher risk of developing toxicity. Next slide, please. So how we've classified the chemotherapy-induced nausea vomiting is primarily based on the level of the chemotherapeutic drug causing emesis. So high, moderate, low, and minimal, which is what we've seen. But there are major limitations, like we cannot say all moderate drugs do fit into the same, or all low emetogenic potential drugs will actually cause only limited toxicities. So it's important for us to understand that there are significant limitations, and it's not like a one-size-fits-all. Next slide, please. So this is where this MyRisk study comes in very effective. So this was basically to look at in patients with moderate emetogenic potential. Next slide, please. So this is the standard guidelines. If you look at MASCC guidelines, so if it's a high risk or a high emetogenic potential drug, it's a quadruple regimen, which is basically looking at a 5-HT3 inhibitor with steroid along with the neurokinin inhibitor and olanzapine. So it's basically primarily you're trying to act the central pathways as well as the peripheral pathways. And for a moderately emetogenic, it's usually a doublet or plus minus triplet, but triplet is not a standard. So that exactly is what was looked at in this MyRisk study. Next slide, please. So these are various guidelines. Next slide, please. All the guidelines kind of primarily say the same, that for major anti-emetic guidelines recommend that for moderate emetogenic drugs, you can just do 2 drugs. So this was a phase 4 study, basically a randomized multinational MyRisk trial. What they looked at was they looked at netiupitint along with pelenosatron for patients with high risk. Next slide, please. So in patients who had chemo-induced nausea and vomiting with moderate risk potential, they stratified it into 2 arms. Yep. Next slide, please. So when you stratified it into 2 arms, they primarily looked at, so this was what they wanted to do was it was primarily looking at a different modality or doing a personalized way of coming up with scores. So how they classified patients as high chemo-induced nausea vomiting risk score. So this is, again, remind you, this is only in moderately emetogenic drugs. So in the moderately emetogenic drug, they came up with a patient-specific risk score. And they classified that as high risk if you have a score of more than 13 based on these parameters, based on age and all of it. And then the primary rationale for them to combine these combinations were because netiupitint is known to kind of act on the delayed vomiting, has a prolonged suppression of the neurokinin inhibitor, whereas pelenosatron, which is primarily a 5-HT3 inhibitor, also helps in the acute phase and has a prolonged receptor occupancy. So it was a good rationale, a good biologic rationale for them to combine netiupitint with pelenosatron along with DEXA versus the standard of care, which is just pelenosatron with DEXA. So when you look at it, this was a multicentric study, multinational study. Next slide, please. So the primary endpoint of this particular study was looking at complete response. So how they defined complete response was basically patients having no nausea, no rescue medications needed during the overall phase after 3 consecutive cycles of chemotherapy. And the secondary endpoint was primarily looking at the acute and the delayed overall phases across 3 cycles. They were looking at whether there was any complete protection, how many needed rescue medications, no nausea, no vomiting, and looking at the QOL as well as the safety. Next slide, please. So if you look at the patient demographics, both were evenly matched, pretty much the same across cancer subtypes were included. Again, majority had a very good performance status and predominantly female rich, or rather females were approximately around 40% in both the arms. So both the arms were very evenly matched along with the exposure to platinums as well. There was enough amount of patients who did get carboplatin. Next slide, please. So when you look at the primary endpoint, that is basically complete response. What we mean by complete response is basically no nausea or no vomiting given for any cycle during the whole process. When you look at it, the odds of achieving an overall complete response in any given cycle across 3 cycles were significantly higher in the experimental arm, which was basically the netiupitint with pelenosatron along with steroids. So which says this is in terms of hazard ratio of 0.12. Next slide, please. So the secondary endpoints were also met across. So if you look at the secondary endpoint, the odds of achieving a complete response in any given cycle was significantly higher with netiupitint and the pelenosatron group. This again, more than the acute phase, it is significantly effective in the delayed phase. So again, people who have these anxiety or people who are more nauseous, people with other motion sickness kind of issues actually had a significant benefit when we used netiupitint along. Next slide, please. So the other secondary endpoint in terms of no nausea rates by cycle, definitely the no nausea rates were also significantly higher in the experimental arm, both in the delayed and the overall phases. Next slide, please. So this study, so this is again the same subgroup analysis. When you look at the estimated CR in no nausea rates, these were definitely higher in the experimental arm compared to the standard of care arm. And especially during the delayed and overall phases in the subgroup, so there was more benefit because the current standard recommendation for a moderately emetogenic drug potential is always a combination of 5-HT3 with DEXA, which is basically a palinositron plus DEXA combination plus minus olanzapine if needed. But adding a netupitant kind of a neurokinin inhibitor, especially in the moderate emetogenic potential group with patient-specific high-risk factors like the ones which we looked at, especially looking at the score of more than 13 based on elderly patients, sex, motion, based on the female gender, age, and all of these parameters taking in and seeing if they're fitting in. So this patient-centric, more risk-predictive model could probably be the way moving forward. Next slide, please. So all the secondary endpoints did have, and there was no significant impact on the quality of daily living. Next slide, please. So with this, if you look at the overall summary of adverse events, pretty much nothing to kind of dissect out from. There's absolutely nothing new which we've seen. There is no significant differences which were observed in both treatment-related as well as treatment emergent adverse events. There's absolutely nothing to choose from. So adding netupitant was definitely safe and also does help in decreasing the nausea, especially the no nausea and the complete responses in patients. Next slide, please. With this, I would like to conclude, which says that there was with the experimental arm, which was observed challenging one, and also with the study what was shown. So clearly, this is something to note and something to incorporate in our day-to-day practice. That especially in this certain subgroup, we're using carboplatin, patient with anxiety, patient with female gender, younger, or patients who've had more hyperemesis gravidum during that. So these are kind of indicators for us to choose going for a quadruple regime, even in the moderate risk group. With this, I'd like to conclude. Thank you and happy to take questions.
Thank you, sir. With this, we have come to the end of our session. Over to you, Dr. Ravi, sir, for the conclusion and the closing remarks.
Yeah. I thank you all faculty members for participating in this wonderful meeting. I thank our sponsors, Zydus, Glenmark, AstraZeneca, Roche, for sponsoring these sessions. And I thank Horizon for helping us to conduct this meeting. And I thank Adley Labs in collaborating for these academic events. So with this, we'll conclude the session. Thank you and good night all.
Good night, everyone.
Thank you, sir. Good night.
Good night.